Good morning, and I'd like to extend my welcome to you as well to the Head and Neck Cancer Victorian Tumour Summit. You can all hear me? Yep. Look, the aim of the summit, as was explained to me, was to identify areas of unwanted variation in the care of head and neck cancer patients across all of Victoria, and to identify areas that might be improved. So that's really what we're looking for here, areas where we think that interventions can be made that will improve cancer treatment across our state. It's not meant to be a judgmental exercise in any way, shape or form. I'm going to present quite a bit of information to you, and there's some printed copies of the charts and things on the table, so you can have a look at them as well. The members of the Head and Neck Cancer Summit Working Party are here, a mixture of ENT head and neck surgeons, fascia max surgeons, medical oncologists, radiation oncologists, allied health people, dietitians, speech pathologists. Very, very, core to the whole process for us was support from the statistics people. Ella, who unfortunately is at a funeral today, so a relative has tragically died, actually related to a head and neck cancer, and Luke, who's here today, who really provided all our statistical information for us. And supported by the Tumour Summit team from the Department of Health, Llewellyn, Morella, Rebecca, Amy and Claire. In the interest of full disclosure, I clarify that I am an ENT head and neck surgeon at the Alfred, and that my co-chair, Andrew Coleman, he's a radiation oncologist at the Moorabbin campus of Peter MacCallum. I don't think we've got any overt agendas to run, and we certainly haven't received any payment for the work that we've done for this. We did get one dinner in queue. So what I'm going to present in this presentation is the overall characteristics for head and neck cancers in Victoria, incidence and survival, the volumes of surgery and radiotherapy that are being done in the different centres, the movement of patients from areas from where they live to where they might get treatment, what treatment planning's been done. We're going to look at the timeliness that patients are receiving treatment, and we're going to look at the treatment and survival outcomes for a couple of the larger groups of the subsets of the head and neck cancer in the oral cavity and the oropharynx. We're focusing mainly on these two sections of the optimal care pathway here, where we have some data to guide conversation about variations in care, really. We think this is where our area of expertise is at the moment. Now the data, it comes from the Department of Health and Human Services linked data set. The Victorian Cancer Registry has been used to identify all head and neck cancer patients, so the pathologists send a cancer diagnosis into the Victorian Cancer Registry, and then those patients are all linked with hospital inpatient data, with radiation therapy data, and the National and Victorian Death Index. It will also present some data from two unlinked sources, the Cancer Services Performance Indicator Audit, which looked at the rates of MDM utilisation, and also at the Malnutrition in Victorian Cancer Services Point Prevalence Study, which was done in 2016, looking at the incidence of malnutrition in cancer patients. So the good things about the linked cancer data set is it's pretty solid and it's statewide. It's sort of population level data, so it's good for giving overall patterns of what's happening. It doesn't identify any outpatient or any out of hospital care that patients might have received, and it does rely on coders who are coding the discharge, coding the medical records when they're discharged to accurately record the diagnosis and the treatment that patients had. And we don't have any direct specific information about disease features, in particularly staging. We don't have TNM data or things like P16 status, sort of pathological data. So we're able to use proxies for some of these things, particularly for distant metastases and for regional metastases, where it's been recorded that a patient has distant metastases or been recorded that they've had cervical lymph nodes. In the Hume Regional Integrated Cancer Service, it's on the border between Victoria and New South Wales. Our data is all Victorian data. Some of the people up there have surgery and chemotherapy in Albury, which is in New South Wales, so we don't capture any of that data. So looking first of all at the overall demographics for cancers in Victoria, we'll see that the overall incidence of head and neck cancer has declined quite reasonably, from over 14 to around 10 cases per 100,000 since 1982. But because of the increase in population in Victoria, the actual physical numbers of people with head and neck cancer still has increased over that time. And interestingly, there's the oropharyngeal tumours that in men have actually increased in incidence since 2008, over the last 10 years. We believe this is due to the increased numbers of human papillomavirus related tumours, which are the sort of new kids on the block, rather than the smokers and the betel nut chewers that are developing. But again, we can't be 100% sure about that on the data that we have. Head and neck cancer is a bit more varied, perhaps, than some of the other tumour streams. The main and the subsite that you have the cancer has a big impact on the treatment that you might need, and the outcome that you'll be looking at in terms of quality of life and survival. The main categories, oral cavity and oropharynx, were the two largest groups. Salivary gland, nasopharynx, hypopharynx, and larynx were the other main categories. One of the things that's interesting with the pathology tumour with the cancer registry, they don't collect data for skin cancer, and for skin cancer metastases to parotid, they're excluded. I think they just thought there was too many of them in Australia to be able to do it. And looking at the proportion of patients that present with cervical lymph node disease, probably as expected, that's highest in the oropharynx, nasopharynx, and hypopharynx, relatively low in the oral cavity salivary tumours and the laryngeal tumours. And so to get this information, we've reviewed the diagnosis codes from hospital admissions up to 4 months after diagnosis, looking for a diagnosis of cancer in the lymph nodes of the head and neck or distant metastases. And you'll see the distant metastasis range is not very dissimilar for all of the groups, sort of in the 5 to 10% range overall. Looking at their overall survival, the overall survival's reasonable for head and neck cancer. Average overall 5-year survival was 63%, with the hypopharyngeal tumours doing statistically worse than the other groups, which is also well recognised in the clinical sphere. When we tried to break it down a little bit to look to make some comparisons between different groups of treatment care, we've used the Integrated Cancer Service regions, which are these, and there's 3 metropolitan ones. Each of these dots represents a treatment centre that treated at least 3 patients over that time. They're unidentified, the results that we have, so we don't specifically know if one individual centre's, well, I don't anyway, performing better or worse than anybody else. In terms of the volumes of surgery, this is the average yearly number of head and neck cancer surgery admissions. You can see there's quite a large variation in the number of patients treated per year, with a long tail both in private here and in public, particularly. That's private, sorry. There were 13 public and 26 private hospitals that had less than 10 head and neck surgical admissions for head and neck cancer in the year, and the highest is sort of up towards 100. Similarly for radiotherapy, and probably even more so, there's a centre doing a large number, and the other centres doing smaller numbers, with again a tail of 5 public and 7 private radiotherapy centres providing treatment for less than 10 patients per year. And we think that it might be important to consider the service capabilities of centres with lower volumes of patients, and in particular whether they have access to specialist nursing, speech therapy, dietetics, etc. that's required for the care of head and neck cancer patients. Interestingly, the optimum care pathways recommend having at least 100 cases per year, and there's only one centre in Victoria that actually achieves that. Now this is quite a busy slide looking at patient movement across the different regions, and so this is the ICSF residence. So it's where the patients live, and this is where they're getting their treatment when surgery is their first treatment. And you can see that surgeries, if you live in Smicks, West Central, Barwon, and to a lesser extent Grampians up Bendigo, then the chances that you're getting your surgery within your region are pretty good. But there's other regions where most people are getting their surgery outside their region. And even more so for radiation treatment. There's a large number being treated in the West Central Metropolitan Integrated Cancer Centre. Barwon Southwest, most patients get their treatment in their region, as did in the Grampians, but all the others, the majority of people will leave their region for treatment. When we looked at the treatment planning that patients were receiving, we believe that MDM treatment planning is important, and it's a recognised standard of care in looking after head and neck cancer patients. The audit that I referred to earlier included mostly public hospitals with very few private hospitals. Overall, 86% of head and neck cancer patients had a multidisciplinary meeting recorded in their patient record, although there was a lower rate recorded in Barwon Southwest and Loddon Mallee. We then looked at which patients had had their MDM prospectively after their first step of treatment, which in the ideal world would probably occur. And there was a high rate in the study that we found. Overall, 84% of people were did have their MDM recorded before their treatment started. We don't know quite whether the treatment that they had was exactly what was recommended by the MDM or not. We don't have that information. Looking at the time to treatment, this is the timing recommended in the optimal care pathway, and I think most of us would agree that it's pretty reasonable. From the initial referral, you allow 2 weeks to get to a specialist, then allow 2 weeks to have an MDM, and then allow 4 weeks to have definitive treatment start. So overall, it's an 8-week period from initial referral to start of treatment. And then for those people that need adjuvant radiotherapy, the recommendation is to have that started within 6 weeks of their surgery. So looking at the patients that had surgery as their first treatment, overall 93% of patients got their surgery done within 8 weeks of their diagnosis, so that looks pretty good overall. And it was pretty consistent whether you were a regional patient in regional centre, or metro centre, or a metro patient in metro centre. This box plot shows the spread of the number of days for surgery for each of the ICSs, with the red line being the 8-week mark, and no statistical difference between the different ICSs was found. In the funnel plot on this side, these are the individual treatment centres. And with these funnel plots, the chances that you're statistically different to the average is recorded by these lines, and the chances of being, if you're outside the first line, is the P is 0.05, if you're outside the second line, the P is 0.001. And there were 4 campuses, when you look at it on a campus level, that had a significantly lower proportion of patients getting their treatment done in the 8 weeks from diagnosis. When we look at it for patients having primary radiotherapy or chemoradiotherapy, overall 77% of patients started within 8 weeks. This time there was more variation in where you lived and where you had your treatment, with a lower rate of people that lived in regional areas and having regional treatment getting their treatment started within that 8 weeks. If they went to the city or they were started in the city, it seemed to be better. The box plot here for number of people treated shows that a significantly lower proportion in 2 ICSs were able to get their treatment started within the 8 weeks, which are these two. And that 1 ICS had a high proportion of treatment being done, which was the mixed group over here. And the funnel plot again shows maybe, again, one centre that's got a really lower proportion of patients starting their chemotherapy or radiotherapy within that 8 week period. Now, if we look at the time from surgery to starting adjuvant chemotherapy and radiotherapy, there's quite good evidence that the time from surgery to adjuvant therapy shouldn't be more than 6 weeks. So we think this is quite an important area to look at. And the data that we've been able to access showed that overall only 37% of patients were able to start their radiotherapy within the 6 week period. But interestingly, this changed quite a lot. Our study is from 2012 to 2016, so it's all a couple of years old at best, and there was certainly a much higher rate over that 4 years, over the time of that, over that 5 years, of people getting treated, although still only 46%. And in terms of time to get treated, there were a couple of ICSs below the state average, indicated by the red asterisks. There's only one now. And 1 ICS above the state average with the blue asterisks, which is this one. So there seemed to be a bit more variation in the post-surgical radiotherapy. Yeah, these ones are the ones outside the 6 window. These are the ICS of their radiotherapy. This is the ICS of their surgery. So there's a couple of the radiotherapy centres seem to be taking longer, and one seemed to be a bit quicker. And this is by the centre, looking at the funnel plot again by the centre of surgery. And again, there's a couple of centres that seem to be outside the statistically worse than average. There's also a couple of centres that are statistically better than average, which is interesting. We looked at the emergency admissions following and during radiotherapy, really as a proxy for the quality of care that the patients are receiving during their radiotherapy treatment. And unsurprisingly, the need to be, the risk of complications really in patients having chemoradiation was higher than in patients just having radiotherapy alone. And there wasn't really any significant variation with that, except possibly one centre there's having a few more complications. Looking at the malnutrition, it's well known amongst clinicians that the malnutrition in head and neck cancer has a significant impact on their outcome, treatment response, treatment interruptions, unplanned admissions, length of stay, quality of life. So the study assessed malnutrition across 10 metropolitan and 2 regional hospitals, and overall 31% of head and neck cancer patients were malnourished, which is higher than average, and again I don't think the clinicians would be surprised by that. It's 23% for all tumour streams. There didn't seem to be any strong variation between the regions. But of some interest is that the percentage of patients receiving dietetics care, there did seem to be some variation with lower rates in the regional centres. So now looking at the 2 larger subsites, at their treatment pathways and their outcomes. Firstly, for oral cavity cancer, the majority of patients had surgery, and 35% of them went on to have adjuvant radiotherapy. A number of patients have neck dissections for oral cancer treatment, and looking at the prophylactic neck dissection rate, statistically it was a little higher in the West Central metropolitan area, and looking at the number of patients having adjuvant radiotherapy or post-operative radiotherapy or chemoradiotherapy was a little lower in the Bowen Southwest region. Didn't seem to be variation for those patients who were lymph node positive. Encouragingly, we saw no difference in survival looking at the oral cavity cancer patients by X of treatment, and although as expected the patients with lymph node disease had worse overall survivals than those without. Now looking at the oropharynx and the base of tongue, a bit more varied treatment. About half had primary chemoradiotherapy, almost 10% had primary radiotherapy alone. About a third had surgery to start, although 2/3 of those ended up having radiotherapy as well, adjuvantly. Looking at the treatment, looking at the survival of the oropharyngeal tumour people, found that patients treated with radiotherapy only had a significantly poorer survival compared to the average, with no difference found between the other groups. We thought this might be related to, and you can see it here, this is the radiotherapy alone, this is the average, everyone else overlaps each other. We thought maybe that's because it's the old people having radiotherapy because they can't have chemoradiotherapy. So we looked at just the patients under 70 years old, and we still found that those that had radiotherapy alone had significantly poorer survival than the rest. But overall, there was no statistical difference between the survival outcome of people having chemoradiotherapy in the different regional or metropolitan ICSs. So in summary, what we think we know from the data is that head and neck cancer has the age standardised incident has decreased. The majority of patients have surgery or radiotherapy within the 8 weeks of their diagnosis. There doesn't seem to be any difference between the ICSs in terms of outcomes, in survival outcomes for either surgery of the oral cavity cancer or chemoradiation for base of tongue. And we think that overall these are pretty good, consistent results. There are some variations in the data. There were many centres providing treatment for quite small numbers of patients. You know, less than 10 is another arbitrary number that we've used. Many patients do have treatment outside of their ICS, outside of their region. There was variation in proportion of the patients treated, who had documented MDM discussion anyway, with lower rates documented in Bowen Southwest and Loddon Mallee ICS. Fewer regional patients who were treated regionally with radiotherapy were able to start their treatment within the 8 weeks. And of all patients having adjuvant radiotherapy, only 37% started within 6 weeks. And again, lower rates were found in Bowen Southwest and Grampians ICS, and there was one metropolitan and one regional centre that looked to be have lower rates. The proportion of patients receiving dietetic care might be lower in the regional centres. And we found that there were poorer survival rates for oropharyngeal cancer patients who were treated with radiotherapy only compared to other treatment types. Some of the things that we would like to know a bit more about is how the patients feel about some of these things in terms of having to travel for their treatment, what sort of treatment they might have, what support services are available to them. I think a lot of the clinicians would very much like to have stronger data in terms of TNM information, in terms of recurrence of tumour, and in terms of other pathological features, particularly P16 status. We'll be interested in the concordance between the MDIM recommendations and the treatment the patient's given. And we're also interested to know whether low volume centres have the service capability for the patients that they are treating. And again, thanks to Catherine and the Cancer Registry and the malnutrition people for providing the data, and to the Victorian Integrated Cancer Services and Department of Health for funding the project.